Pharma for an educational grant which helps us to live webcast these classes, and we also thank Dr. Radha Gildial and the Dean of San Hospital for allowing us to conduct these classes here. Today we have two cases. The first case is by Dr. Srihari from San Hospital, so we'll start with that case.
Good evening everyone. 10-year boy, second by birth order, born of third degree consanguineous marriage, resident of Mankud, hailing from Jalna, Hindu by religion, Nadbaje by community, with mother as informant, comes with the complaint of loss of developmental milestone since 16 months of age, and cough cold since 3 days, and increased respiratory activity since 3 days. History of presenting illness. Child was apparently normal till 16 months of age. Then parent noticed tightening and twisting of limbs while doing daily activities for less than a minute, associated with crying, and initially for 2 to 3 times per day, and progressed to 10 to 12 times per day, and associated frequent falls while walking and decreased daily activities, followed by progressive loss of ability to walk, and followed by inability to stand and sit, and then lost the ability to turn sideways by 2.5 years of age. Child could move limbs on the bed and is associated tightening of limbs, difficulty in changing diapers and clothes. Child also stopped holding objects and reaching for objects, and not fixing following the surroundings. Child also progressively lost the ability to speech in the form of decreased word output initially, and then also stopped responding to the commands. For the above complaints, medical attention was sought and neuroimaging was done and started on medication, and regular exercise of limbs were taught. Complaints of cough since 3 days, not spasmodic, wet cough, increases with feeding and associated with post-test vomiting, associated with fever since 3 days, low grade intermittent related medication, and complaints of increased respiratory activity since 3 days in the form of increased rate and depth of respiration. Multiple past history of similar complaints present, and multiple past history of admission for similar complaints present. No history of bed sores, no history of constipation present. Passes stool once in 3 to 4 days, hard stool. No history of seizures, fever, vomiting. History of nasal regurgitation of food present, associated with emotional lability. No history suggestive of any cranial nerve palsy. No bowel bladder control attained. No nystagmus, swaying while child and other no nystagmus, swaying while child was walking. Other involuntary movements. Family history suggestive of similar disease in all the siblings present. Neurodegenerative no history suggestive of dysmorphic faces. No history of abdominal distension. No history of abnormal odor of urine. No history of any abnormal skin pigmentation, hair changes. Family history of similar disease in the siblings present. First child had similar complaints, started at 2 years of age and expired at 2.5 years of age. Third child had similar similar complaints, onset at 1.5 years of age and expired at 1.5 years of age itself. Fourth child, onset 1.5 years and has lost all the milestones on regular treatment and follow-up. No history of similar complaints in other members of the family. Developmental history. The child had attained all the age appropriate milestones till 14 months of age. Then the child lost all the milestones by 2.5 years of age. Now the child in gross motor cannot do head holding, and in fine motor there is no the hands are open, no fixing following present, and social, no social smile, no bowel bladder control. Language, no response to the commands. ANC birth and ANC history was uneventful. Registered pregnancy, all the supplements were taken and ANC scans were normal, fetal movements were perceived well, and natal history also, it was a full-term normal vaginal delivery, baby cried immediately after birth, birth weight was 3.2 kilo, discharged on day of life 2, uneventful, immunized up to 1.5 years of age. Diet history, child's complementary feeding was, child was on complementary feeding and was taking feeds well before, then pooling of food items in the mouth started. Now child takes only semi-solid food items 3 to 4 times per day. History of frequent regurgitation of food from nose and mouth present. 4 food groups are involved in the diet. Calorie deficit of heightened kilocalories and protein deficit of 8 gram proteins present. And child belongs to lower socioeconomic state according to modified Kupuswamy classification.
Okay, so what do you make out of the first complaint at 16 months of age? Tightening and twisting of limbs while doing daily activities associated with crying, and which gradually progressed.
It could be dystonic movements.
So how will you confirm that on history?
Means stimulus, at the time of any stimulus, the movements are aggravated and disappears in sleep.
Okay. So now if you think this is dystonia, then what next? At that stage, what would you think of next? Means what could this be?
Usually present in cerebral palsy children.
Okay. So
Basal ganglia involvement of basal ganglia.
yeah, basal ganglia involvement. So that's the anatomy. Now you said usually present in cerebral palsy. So now take that further, that statement further. So would in a cerebral palsy, would it start for the first time at 16 months of age?
No, sir.
So that's ruled out, right? Okay, so what else? What else can it be?
Can it be a seizure? The child has episodes of tightening associated with that, followed by crying many times a day.
Could be seizure also.
Can it be a seizure? So this child has seizures from 16 months of age. They are progressively worse. Anything against seizures?
It usually occurs only in the awake state, and it is stimulus sensitive. When the parents do some activities, the child gets tightened.
Yeah, but some
And
of
it
the
is associated
seizures are sensory stimuli precipitated. You know, the hot water seizure and stimuli may precipitate.
So what question will you ask which will rule out that this is a seizure on history?
Whether child was unresponsive during
Whether
the
child was responsive is a better word, because when you say unresponsive, it means that he's totally unconscious. So you want to know whether he's responsive.
So what questions will you ask? I am a lay mother.
whether child was looking around, whether child
No, when he was getting that, he was only crying, not looking around.
crying itself is it is a response to the surrounding.
Good. Crying itself is a response, and they don't have crying while actually is seizure. They may have it. Anything else in addition? Suppose the child was limp, not crying. Anything else will you ask? This child suddenly became limp or maybe tired. His eyes were closed and he was like that.
Post seizure, they usually go to drowsiness, post-ictal drowsiness.
Pardon me?
Post seizure, they if it is a seizure, they go to post-ictal drowsiness or something like that.
And during seizure?
During seizure, they will be not responding to the surrounding.
And eyes may often be open during seizure. It's often not recognized that eyes are open. Then later on they may have. So there are actually several points against a seizure in this particular child. The child was always aware, they are coming one after the other, etc. So that's one thing. So he started with something at 16 months of age, and till then he was normal.
Yes, sir.
Okay.
Okay. Now we discussed that cerebral palsy thing. So you need to obviously confirm on history that before that he was absolutely normal and doing all development normal and all other activities normal. Now after that there are so I was saying, what else will you think of if a child starts with dystonia at say 16 months of age? You said anatomy is basal ganglia. What is the pattern of that complaint? Is it getting better, getting worse?
Progressive.
Progressive. So progressive The pathology is progressive. So is it happening suddenly in 1 minute, or it is happening over a period of time?
Happening over a period.
Over a period of time. So it's a progressive pathology of the basal ganglia, infective, non-infective?
Non-infective.
Non-infective. So what can it be? So it can be neurometabolic, it can be degeneration, it can be even your hereditary dystonias, your dopa responsive dystonias and so many others. So at that stage your field is wide open. You don't know what you are exactly dealing with at that stage, right?
But this particular child could be CP also, a dystonia. The neonatal jaundice was not noticed and now he has dystonic CP. Number one, is it CP and can you have a dystonia secondary to kernicterus? It can be subtle kernicterus. You know, many times you have seen bilirubin 18-19, child is relatively alright. So dystonic CP, number one, why is it CP at all? Or why is it not CP at all rather?
So it's a progressive pathology. So
In what tells you that it is progressive?
so there is till 16 month the child is achieved, and thereafter there has been regression of the milestone. So
That means in what way? He started getting the spasms and the spasms progressively worsen. What exactly is there to suggest progress associated with frequent falls, with walking, decreased daily activities followed by progressive loss of ability? So this is what is telling you that he is progressive. Initially it only started with postural abnormalities. Then it started with inability to walk and now it has resulted in that. That is why posture. So that's a strong point against cerebral palsy, because cerebral palsy is non-progressive.
Okay, now you come to the second complaint, frequent falls. So last time or the time before that we had discussed frequent falls. I don't remember which time. So can somebody quickly enumerate all the various causes of frequent falls that you have to think of when a patient comes to you?
It could be local, like muscular causes. It could be peripheral neuropathic causes. It could be spinal cord lesion. Then it could be cerebellar lesion because of ataxia. Then it could be due to central causes because of the loss of power.
Yeah. So lot of neurological causes. So the anatomy could be power related, tone related, balance related, involuntary movement related. So all that in CNS, central and peripheral both, and non-CNS causes of frequent falls.
Could be nutritional.
Okay, how?
Generalized weakness child.
Okay, that doesn't generally come with frequent fall. So it could be vertigo, it could be vision disturbances, okay, so the night blindness, so many things. So you have to keep your mind wide open for all these possibilities when somebody comes to you with a complaint of frequent fall. Now followed by progressive loss of ability to walk. So does that tell you anything, or you want more details? So if you want to try and decide the anatomy as to where is the problem, how will you get to that? So why is he not able to walk now? What has gone wrong? And the second thing, which anybody has a question which I have in my mind?
Means is he not able to walk because it is a loss of a milestone, or is it power related?
So that is one. Secondly, it is about over what time frame has all this happened? Can you give us an idea?
From 16 months till it has occurred over a span of 1 year. From 1.5 years to 2.5 years. The mother collectively doesn't remember properly what over 1 year what has happened.
But by 2.5 years,
yes, the child has lost all the milestones.
okay. So in a span of about 1 to 1.5 year, everything has happened. Okay. Now, can you answer this, that loss of ability to walk was it associated with any affection of power? So how will you ask that? Was he able to move his limbs?
Yes, child could move limbs now also, but associate tightening. Just he cannot stand up or walk.
So that means what?
Power is preserved if he can.
But what is affected? Associated with tightening, no? So what is affected?
Tone.
Tone. So tone is increased. So this is pyramidal or extra pyramidal? In both you get an increased tone, right? Pyramidal as well as extra pyramidal. So which one is this?
In pyramidal it will be sustained, in extra pyramidal it will be episodic.
That is on examination. That is on examination, your clasp knife and your cog wheel. But on history, how will you find out? Any thoughts?
Sustained posture of the movements, less movement of the limbs.
So ulta, let's go ulta. Tell me classic signs of pyramidal involvement. Start 1, 2, 3, 4. Symptoms of pyramidal involvement, not signs.
It will be associated with weakness.
Excellent. So weakness is a hallmark of pyramidal tract involvement. It's upper motor neuron disease, right? So in extra pyramidal there is hypertonia or spasticity. On history we are talking of, but no weakness. But in pyramidal there has to be weakness. So that is a difference. So this, if there was no weakness, then this sounds like a progression of that extra pyramidal, which started as dystonia and went on to involve the tone of the muscles, because of which he stopped walking, right? I mean walking, standing, whatever. Then lost ability to turn sideways. Do you think this can be only due to tone? What do you think?
So basically loss of roll over milestone.
Correct. So what I'm trying to say is, this is not just because of tone. So I'm just trying to say that till a stage prior to this, all that you had was progressive extra pyramidal involvement, which could have been anything. It was a wide range of things. But inability to turn to one side is either related to power, or then it is related to that cognitive development being lost, so that milestone being lost. So you need to start thinking of that. Of course, simultaneously, so we are just focusing on the motor abilities here, but simultaneously what happened to his other things, so that is there in your thing, that he progressively lost ability to speak, right, in the form of decreased word output, then stop holding objects and reaching for objects. Okay, now what does that not fixing tell you? He stopped fixing at objects. So what does that tell you?
Visual.
So what is happening to the vision? If he is not fixing, so how will the mother tell you he is not fixing?
Not interacting with the mother. Not interacting, not responding to the mother, not seeing the mother's face.
So that could be just visual loss, no? It could be visual loss. So on history it is difficult to say whether it is visual loss. Now visual loss and fixing go hand in hand. So you fix and then you focus, right? So if there is extreme visual loss, it may appear that you are not able to fix on any object, correct? So where is the anatomy of that? Not, or losing vision progressively, where is the anatomy?
Occipital lobe.
Occipital lobe.
Optic atrophy could be the lobe. It could be optic atrophy, retinal degeneration.
Yeah, so the anatomy could be anything from the cornea to the occipital lobe. So it could be a progressive corneal opacity and you can't see, to a lens problem, to behind a retinal problem, to the optic nerve, to the occipital cortex. So the anatomy could be anything. So on history, it's not easy to decide. If you correlate with the other findings that are happening in this child, then what do you think? White matter is being involved or grey matter or both?
Initially grey matter, then followed by white matter is getting involved.
Very good. So the first symptom was grey matter, and then the tightening etc. was involvement maybe of the white matter also, and then again there are some things which are of grey matter, some things which are of white matter, right? So you have both involvement. So you can extend that and think that he is probably getting into optic atrophy. Okay. So now at this stage, how would you sort of, just at this stage, describe the whole thing in a few words?
Just one moment before. It all started at 16 months. The cognitive milestones were absolutely normal before that.
Yes, child was walking, child was running, playing, everything. Cognitive, child was responding.
Child was looking at the mother,
Yes, yes.
speaking, recognizing.
Yes.
He had developed singularity.
The child was speaking bisyllable by then.
So he was absolutely normal before that, and then he started losing the
Losing
milestones.
milestones.
So the first evidence of losing the milestones was in the form of so-called spasticity.
They noticed tightening of limbs while walking.
Okay.
So can somebody now put everything in 2 or 3 sentences? Come on.
It is a gradually progressive neuroregression involving both white and grey matter.
Very good. So now about gradual progression and rapid progression, of course there is no definite timetable, but in a period of 1 to 1.5 years, this child has become bedridden, right? So you might as well say rapid also, rapidly progressive neuroregression affecting grey and white matter both, okay, in a child who was developmentally normal earlier. And then what else? I mean, or we can go ahead. Let's go ahead.
What I thought is his child was already almost normal till 16 months and started with either dystonia or spasticity. So what was affected first? White or grey?
Since it was dystonia first, it is grey.
If it was spasticity, so you were sure that it was started with dystonia, which is rotatory movements of the hands or the legs, and then came the spasticity.
Yes.
So if otherwise one may give importance to spasticity as the first manifestation, and you may be tempted to say, because the other grey matter related problems have come quite late, after 15-16 months of age. So if it has started only with spasticity without dystonia, then one wonders whether this was white matters to start with. But if it was dystonia to start with, we will see that. We'll keep both the things in mind, but perhaps dystonia is a point in favor of grey matter.
Then child developed cough. Since the child basically developed LRTI in the form of cough since 3 days, not spasmodic, wet cough, increase with feeding and also post-test vomiting, and also fever since 3 days, low grade intermittent, relieved with medication, and increased respiratory activity since 3 days. Multiple past history of similar complaints present, and multiple past history of admission for similar complaint is present.
Yeah, so what do you make out of this?
Basically, it could be aspirational pneumonia since the child, it increases with feeding and multiple past history for similar complaints and admission.
Okay. So why is he aspirating? Possible reasons?
There is history of regurgitation of food present.
Exaggerated gag reflex.
Sorry?
Exaggerated gag reflex in
Okay.
UMN palsies.
So pseudobulbar
Pseudobulbar
palsy.
palsy.
Okay. Anything else?
It could be due to loss of muscle tone in the upper respiratory, upper GI tract. That could also be the cause. There could be autonomic instability.
Okay. Fine. Okay. Then you said no history of seizures, fever, vomiting. So seizures, of course, is important because it's another symptom of grey matter involvement. Then, okay, no history of nasal regurgitation, no history of other cranial nerve palsy.
History of nasal regurgitation is present, sir. No history suggestive of other cranial nerve palsy.
Okay.
And no ball.
Sorry, so what was that history of nasal regurgitation associated with emotional lability? So what is that?
Basically, the child cries, not responding to the surrounding cries, then irritable always.
No, so first of all, what is the connection between emotional lability and nasal regurgitation?
To rule out whether it is bulbar or pseudobulbar palsy, I will put it like that. Basically, if it nasal regurgitation can be present in both pseudobulbar and bulbar palsy, with emotional lability, it is more likely to be pseudobulbar upper motor neuron lesion.
Okay. What do you mean by emotional lability? What is our understanding of emotional lability?
Not able to control emotions.
Like on small things, the child will get emotional, will show anger.
So any emotion which is
Out of proportion.
inappropriate or disproportionate to the stimulus, correct? So, I mean, in this child, given this kind of a picture, okay, there is a loss of so many milestones, cognitive, etc. I think that emotional lability is very difficult to decide in this child, and especially at that age of 2.5 months. So I don't think that should come in the history in this child, right? So practically speaking, where will we talk as students of emotional lability, in which situations? In an older child with chorea. So rheumatic chorea, if you have a 8-10-year-old child who's come with choreiform movements, you are giving a history of, you are trying to give a final diagnosis as rheumatic chorea, there you may actually talk of and demonstrate emotional lability, but not in such a small child.
Yeah,
right?
emotional lability means for something which you don't expect the child to laugh, he laughs that. Or for simple things, he cries, which is not appropriate stimulation. But what you have described is more of an irritability rather than emotional stability. So for a reason where you don't expect somebody to show either laughter or depression or crying, you are getting that. While this is irritability, so it will be more like irritability rather, as he said, emotional lability at that age is going to be difficult to diagnose.
But sir, this history has persisted. Now the child is 10 years and the child still have that symptoms with the inappropriate emotions. This negative history was with respect to this age actually.
Say that again. So he still has those symptoms, means what exactly are you saying?
Currently he is 10-year-old, and even though he is 10-year-old, he has those symptoms, emotional disturbances.
Means what happens?
Inappropriately showing, always crying, irritable, not consolable by the parents. At 2.5 years.
No, so that's what I am saying, na, Shri Hari. Not getting consolable by parents and crying all the time. How can we say this is emotional lability? Why is it not irritability? What is the difference between irritability and emotional lability? Irritability is also continuously crying and not consolable by parents. You're getting what I am saying? So, I am trying to say that in a child who's not very, cognitively not very good, it is difficult to make this separation. So you can make this separation in a child who is otherwise talking, doing everything okay, communicating. There it is easy for you to say this is emotional lability. In such a child who is not speaking and not communicating in many other ways, it will be difficult to differentiate. Of course, if we see the child, we may be able to say better, but I think it will be difficult to justify emotional lability, right? Anyway, it was just a point for us to be, understand what that word means. Okay. Now,
no history suggestive of other cranial nerve palsy,
hmm.
and no gallbladder control has been attained till now.
Yeah.
No nystagmus swaying while child was walking, and other involuntary movements are not there. Other involuntary movements.
Fine.
Then family history of similar disease in all the siblings present. No history suggestive any dysmorphic faces. No history of abdominal distension. No history of abnormal odor of urine. No history of any abnormal.
Yeah, all that we noted. So now family history of similar disease in all siblings. You said one was normal, no? Second.
No, he is the second child. All the other children are affected.
Okay. So what does that tell you? What kind of inheritance? Autosomal dominant. Okay.
Can it not be autosomal recessive?
It can be, sir.
A third degree consanguinity suggests what?
Recessive more than.
Yeah. If it is autosomal dominant, that means there is form of rust. That means one of the parents have it, but they are not clinically manifest, and the previous generation had it. Now, previous generation is unlikely because then grandparents wouldn't have reproduced. So every time, if it was otherwise it may be a new change, mutation. But otherwise, autosomal recessive would put it better than autosomal dominant.
Okay. Any other data we have to localize? Otherwise, then we'll summarize, and then Dr. Amdekar sir has made a comment. I'll talk about that. So, anything else after this? Okay. So you said that all the children are affected. Yeah. Okay. So now.
And two of them have expired.
Expired due to what?
They are telling similar illness by 2.5 to 3 years of age. They have, because of some aspiration thing only, because they had increased respiratory distress and were admitted at hospital.
Okay. So now anatomically, which are the areas that are involved? One is basal ganglia. Anything else?
Cranial.
White matter. Anything else?
9/10 cranial nerve.
Okay, so 9/10 cranial nerve. When you say cranial nerve is involved, in that broader sense, is it grey matter or white matter or neither?
It depends. If it is, it could be grey matter or white matter.
Very good. So depending on whether it's a nuclear palsy or an otherwise, you will call it as grey matter or white matter. Where is the nuclei of 9th and 10th situated? Medulla. So did we have any other suggestion of any medullary involvement?
No.
No. So we're just stretching our thought process. So if you are given a choice of guessing, you might guess that this could be white matter involvement involving those cranial nerves rather than the grey matter in the medulla, just because we don't have anything else of medullary to go by on clinical grounds, right? So now Amdekar sir has asked that can it be multiple carboxylase deficiency which has predominantly basal ganglia involvement and which is treatable?
It can be, sir.
It can be. So in our differentials we'll have to definitely keep that. Okay, fine. So now that's all in the history, right? So now you summarize your history.
Summary: 10-year boy, second by birth order, born of third degree consanguineous marriage, with history of regression of milestones, noticed since 1.5 years of age, with dystonic movements, with 9/10 cranial nerve palsy, with feeding difficulties, and semi-solid diet with calorie protein deficiency, and history of cough and cold with similar history in the similar history in the siblings, with the normal antenatal birth history, and is probably a case of neurodegenerative disease with grey matter more than white matter involvement and basal ganglia involvement, with aspiration pneumonia, throughout mitochondrial encephalopathies, lysosomal storage, or any inborn metabolisms like glutaric aciduria type 1 carboxylase deficiency.
Okay. Fine. I think one or two things that you have to add in that is where did it start? So instead of so when you are summarizing, instead of saying with dystonic movements, you say with symptoms suggestive of basal ganglia involvement as in the beginning, and rapidly progressive. That is the other word that you have to say, right? Fine. Okay. Now tell us the examination findings.
On general physical examination, male child lying on bed with flexion at elbow and knee and extension at the hip, with flexion contracture of the ankle. On examination, the child was febrile and with the pulse rate of 120 beats per minute, regular rhythm. Then respiratory rate was 38 cycles per minute, abdominal thoracic respiration. Subcoastal retraction, intercoastal retractions were present. Saturation was 90% on room air. Extremities were warm. BP was within 5th to 50th centile. Sugar was maintained. They were paler. On anthropometry, the child was underweight, stunted, severely thin, and microcephaly was there.
Wait. So, can you give us some more information from this anthropometry? Let's do that habit, which exercise which we do every time. What is the weightage, what is the height age, and what is the chronological age? So what is the weightage?
Chronological age is how much?
10 years.
Weightage is? So at what age is 16 kg perfectly normal? Even younger, 4 years, 4 to 5, so 4 years. Then at what age is 118 centimeters perfectly normal? You are 20 people here, everyone will throw a number, someone will be right. No? This is not the way. Everyone should be right. So chalo, make it narrow. 7 to 8 years. So how do you remember all this? Height is very, very easy. 100 centimeters at, after that 5 centimeters per year. So 118, so add 3, so 7 to 8 years. Simple. Okay. Weight 10 kg at 1 year. After that 2 kg for the next 5 years. So 12, 14, 16. So 4 years. So please use remember these all the time. Okay. So chronological age 10 years. Height age 7.5 years or 7 to 8 years, and weightage 4 years. So what is this pattern of? This pattern is called, okay, but better, so this is seen in two situations. One is chronic systemic disease and the other is chronic malnutrition. In an older child, you never talk of chronic malnutrition as a nutritional problem. It's always secondary to disease. So this is a classic pattern of chronic systemic disease. Right? Okay. Head circumference 46. Any comments? Any comments on head circumference 46?
46 is the head circumference of a dash-year-old child.
4 years.
Chalo, again, 1 year head circumference. Why are you being so measly? Birth head circumference?
33 to 35.
So 1 year is 45 to 47. So 46 is literally 1 year.
Yeah.
Okay, 1 or little above 1 year. So for this child, is it microcephaly? Yes. So there is microcephaly, and why have you written -1 to -2 SD? It's wrong.
Mistake, sir.
It's wrong, okay? It can't be -1 to -2. It has to be less than -3. At 10 years, what should his head circumference have been? Huh? Adult head circumference, which is 52, 54, whatever. So 46 is grossly low, right? So now Amdekar sir has made another point that MCD and glutaric aciduria unlikely as they present as macrocephaly, and this child has microcephaly, right? Okay, go on.
Then head to toe examination. Head shape normal, no dysmorphosis. Head size microcephaly present, no overriding of sutures. Eyes, no clouding of cornea, no cataract. Ears normal, nose oral cavity, nose normal, oral cavity, oral thrush present. Dental caries present. Skin normal, no other neurocutaneous markers. Chest, abdomen, spine normal. Genitals and extremities are normal, no bed sore. Bilateral ankle contractions present. CNS examination. Child lying on bed with flexion at elbow and knee and extension at hip with bilateral static ankle contractures. The child was awake, not oriented to time, place and person. Memory attention cannot be tested. Speech, no word output and no comprehensions were present. Cranial examination.
One sec, go back. So how do you know whether it's static or dynamic contracture?
With movements, with whether R2 and R1.
Describe it properly.
R1 is the movement, the range of movement till the first point of resistance, and R2 is the movement with further further force, with the application of further force, whether the what is the next range of motion with further application of force. If R2 is more than R1, then it is dynamic contracture, and R1 is more R1 and R2 are equal, then it is static contracture.
Very good. What is the importance of knowing this?
Physiotherapy will help only in dynamic contractures. In static contractures, it cannot help.
So what will help in static contractures?
Splints and tendon release surgeries.
Very good. Surgery. Okay. Go on.
Cranial examination. All the cranials are normal. No other defects are present except for the gag reflexes. It is not
one sec.
exaggerated.
Second now we'll see, no?
Second
now is normal or?
Second is bilateral pupil reflexes are present, but the child does not fix and follow. Then field of vision cannot be tested. No menace reflex present.
So where is the lesion? Why is he not seeing? Where is the lesion? So by this information and by the fact that you have seen the eye physically, which are the areas which you have ruled out as the lesion?
Nerve, because pupillary reflex present.
Very good. So pupillary reflex present, that means optic nerve is ruled out. Then cornea?
No cornea.
No opacity, so ruled out. Lens?
No cataract.
No cataract, so ruled out. So you're left with
Retina
retina and occipital cortex, right? Okay.
Also in cataracts or cloudiness, your pupillary reaction may be difficult to elicit if there's a lot of cloudiness there.
Then third, fourth, sixth, moves eye in all direction, no squint, ptosis, pupil mid dilated and reactive.
All that is fine, yeah. So you said 9/10 gag reflex not exaggerated.
Not exaggerated.
So there is no pseudobulbar palsy.
I could not
Means
find.
yeah, you're on at least on that time examination you couldn't. Fine.
The motor system, no asymmetry in the muscle bulk present. All there was generalized wasting was there, but no difference in the muscle bulk. Bilaterally symmetrical muscle bulk was present. No limb length discrepancy. tone was increased bilaterally. It was spasticity was present with modified Ashworth scale of grade 2. Then power moves limb against gravity more than 3/5 in all limbs. Then superficial reflexes, all the reflexes were present. Babinski was upgoing, and deep trend reflexes were exaggerated. Ankle clonus was present. Then sensory and cerebral system cannot be tested. There were no meningeal signs, no primitive reflexes. Spine was normal. Bilateral static ankle contracture was there. Bilateral dynamic knee contracture was also there, since the child was in flexion posture.
Okay. Is there anything more you would like to mention? A child who has neuroregression. Could he have gone down and achieved something which was present in the neonatal period? That means regression to of the reflexes, like those were present. You may just mention whether there is rooting or there is what we call tonic neck reflex present. That's one of the causes why the child is not able to turn. So regression to what extent also you can say. If he has rooting, then now that he has gone to almost neonatal period. So all degenerative, he has come down, but not so much.
Now on examination, what were the signs mainly suggestive of? On history we discussed between pyramidal and extrapyramidal. On examination, what were the signs? Pyramidal signs, right? So we didn't get the cogwheel rigidity, and we did get spasticity and upgoing plantar and brisk reflexes.
No dystonia also. When you stimulated, he didn't have any dystonia?
He episodically, every day he was having, sir. But on examination I could feel spasticity. It was velocity dependent, not rigidity. Dystonic movements were there on the history, and we could see dystonic movements also.
So it was pyramidal and extrapyramidal involvement, right? Okay. Now Dr. Mahesh Mohite is asking that clinical disease started at 18 months and head circumference of 1 year. So when did the disease actually start? So what is your thought process?
It would have started,
but parents noticed little late. That could be, or this is
probably in the early infancy, because head circumference has only achieved till 1 year of age. So maybe until 3 months he would have achieved a normal head circumference, after which the growth had slowed down. The head growth had slowed down.
So would you say 3 months? So again, now we have to divide the growth of the head in the first year. So that 35 to 47, what is the breakup?
2 centimeter per month for the first 3 months.
So literally at 3 months, it almost becomes 41. Okay. Right? Yeah. So if the disease started at 3 months, then 41 to 46 was not possible. Correct? So it didn't start at 3 months. Then
1 centimeter per year, 1 centimeter per month for the next 3 months.
So 44 at 6 months.
And 0.5 centimeter per month for the next 6 months.
Correct. So that's 47. That's the way it is. So you would say that the disease started between 6 to 12 months, going by the head circumference. Right? Because 6 months takka 44 was already achieved, and then the disease started and it slowed down. Right? So it's difficult to, what are you saying?
So from 6 months to 10 years of age, would he have achieved only 1
So that is because by 2.5 though he was absolutely vegetative, na? So 2.5 years, what head circumference you want? 49. So after that, so there was no brain growth only, because he had become already vegetative. The disease is at its peak. So you have to roughly say ke when did it start, so that he reached 46 by 2 years. You understood? Not till 10 years.
Also, we'll take the help that this child's milestones were absolutely normal till about 15, 16 months of age. So had the disease started much earlier, his milestones would have been affected even much, much more than the head circumference. Milestones would have been a more sensitive indicator than the head circumference. So probably 1 year, or maybe that's why his head circumference is 1 year, maybe slightly plus. Around 1 year, perhaps not in infancy, but little later than infancy, sometime between 1 year and 1.5 years. Because when you classify the neurodegenerative disease, at what age started is also one of the ways of helping us.
Impression. 10-year-old boy, second by birth order, born of third-degree consanguineous marriage, with history of regression of milestones since 1.5 years, and with dystonic movements, with microcephaly, with no dysmorphic faces, with spastic quadriparesis, with 9th and cranial nerve palsy, with no organomegaly, with feeding difficulties, and semi-solid diet with calorie protein deficiency, and history of cough cold with similar history in siblings, with the normal antenatal and birth history is probably a case of neurodegenerative disease, with grey matter more than white matter involved, with basal ganglia involvement, with aspirational pneumonia, with static ankle contracture, and GMFCS grade 5 score, probably mitochondrial encephalopathy.
Okay. So, as a group, why not a storage disorder?
Storage disorders, usually there will be grey matter more than white matter, and there will be organomegaly and dysmorphic faces.
So absence of organomegaly is a strong point, right? So it rules out all your Tay-Sachs and Niemann-Pick's and all those, because most of them have hepatosplenomegaly, right? Okay.
I wanted to ask one thing. The only thing because of which we say that this is a grey matter disease is dystonia. Now nowhere in the
cognitive milestones have gone down. He was cognitively fine
till 16 months,
and then he lost his speech and everything. So
no, whether the spasticity started first or the loss of milestone started first.
First it was dystonia, sir.
So dystonia is what the parents have described. If it has started with dystonia, you have not been able to demonstrate one extrapyramidal sign in this particular child. After observation, you have not got dystonia, you did not get cognitivity, none of them. So if it started with dystonia, today we have no evidence of any extrapyramidal involvement, though it started with extrapyramidal. So because it is extrapyramidal, we are calling it a grey matter disease. But his spasticity, etc. came much before 16 months of age. Am I right?
Sir, it's a little grey area, meaning that because one is this child is 10-year-old. Yeah, so getting a history which is 8-9 years back is not going to be that
otherwise
accurate.
If it was spastic first and losing after 6 months, then it was white matter. The only evidence being grey matter of basal ganglia, which I am not getting any signs to.
But in the next 1 year, by the time he became 2.5, he had stopped speaking everything. And stopped.
So grey matter definitely. Whether what started first.
Correct.
Now, once everything is affected, it's all global. But before that.
Okay. Did you examine the fundus?
No, sir. Actually, the child has been admitted with aspiration pneumonia. He has respiratory distress. He is on oxygen currently.
Yeah, it doesn't matter, no?
And he is actually diagnosed case.
No, that's fine, but for our purpose, you must, even out of interest, out of practice, we must examine the fundus, even if we know whatever is the diagnosis. And in the exam, you have to talk about fundus. Otherwise, you can be marked down if you don't talk about the fundus. Okay, go on.
Actually, the child mutation, Sanger sequencing has been done. It is TPK1 mutation, homozygous autosomal recessive. The father and mother are carriers, and till 7 years, the last child was born. When the last child had complaints, they have actually gone for genetic study. Till that time, they were not aware of this.
In so the last child, means this child?
No, the fourth child. This is second child. First and third child expired.
No more.
Expired. And this child also had developed similar complaint. That time the whole family screening has been done. The first child genetic study came out to be TPK1 mutation. Then other members of the family are screened, Sanger sequencing, and it is thymine phosphokinase 1 mutation, autosomal recessive. And MRI brain is suggestive of signal abnormality in the basal ganglia with associated restricted diffusion. The MRI plates are not available; they have lost it.
Okay. Otherwise, routine general investigation, there is nothing.
Anemia is there.
Okay.
And lactate is elevated. Serum lactate is elevated.
Okay, fine. So now, how will you counsel these parents? Try.
So, sir, we can actually start by asking them how much they know about what the child has and build on that, and then means
Yeah, so that's passing the buck. Suppose they don't know anything, then what will you tell them?
we'll explain to them that it is like a disorder which all of their children have been affected with because of the nature of the genetic disease, and about how it has rapidly progressed to affect the child to a stage where he has lost all the milestones. So,
What kind of a disease is this, doctor? What mistake have we done every time? Parents are asking.
Do you have a photograph?
The child.
Eyes covered or something like, especially of the posture.
No,
So, if Tushar, if you are listening, there are questions coming in from other people. So, I don't know what's wrong, but we are getting questions from other people. Yeah, sorry. What were you saying? You are counseling.
We'll tell them that there is no blame in this condition, and
First, tell me what is the condition, doctor?
so this is a genetic condition in which there is a damage to the central nervous system, and it was a progressive disorder in which uh,
Units. Come on. No,
You have
not
to make an
difficult.
effort. You see as if the parents are in front of you, the child is in front of you, and ask, abhi kya karenge? There will be 2-3 different counselings which is good for us to learn. Number one will be what will be, you can start with what this child has just now. Then you can come to what is it for. Then you can come to what do you expect from them. And then the other thing, what is the prognosis for this child and what is the counseling for other children to come. Okay, so what does this child have? Your child has a brain disease. You must talk it in terms which they will understand. Your child has brain disease. Apparently जब शुरुआत होती है तो वो अच्छा दिखता है, लेकिन धीरे धीरे उसके ब्रेन की पावर कम हो जाती है, और जो पहले करता था वो नहीं कर सकता. वो जो 1 साल में करता था वो अभी नहीं कर रहा है. हाथ पैरों पे कंट्रोल नहीं है, और सब बच्चे ऐसे ही चले गए हैं. सो ब्रेन का या बीमारी है, और धीरे 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 वो बढ़ते जाता है, और आखिर में वो काफ़ी आगे चला जाता है. ये बीमारी अनुवंशिक है. आप में डिफेक्ट नहीं है, लेकिन इसमें आधा डिफेक्ट माँ में रहता है, आधा डिफेक्ट पिताजी में रहता है. दोनों अच्छे दिखते हैं, लेकिन कभी इसका आधा और इसका आधा साथ में आ गया तो ही बच्चे को होता है। आपके बच्चे में चारों बच्चों को अनलकीली दोनों का आधा जो खराब हिस्सा था वही आया है। ये बीमारी आपने देखा कि बढ़ते बढ़ते जा रही है, आपके तीनों चारों बच्चे अल्टीमेटली आप बचा नहीं सके। अभी ये बच्चा अच्छा है लेकिन थोड़ा सा बढ़ने का भी चांस है। यू मे नॉट से दैट दिस चाइल्ड हैज अ वेरी, बट पेरेंट्स हैव अंडरस्टूड दैट, and then comes the genetic counseling. So that I want to ask you, what do you want to say? Are they already
So you will tell them not to go for any more children, or what will you tell them?
They are not sterilized, na? Are they sterilized?
Currently they are not yet.
You know, so you may consider that. So what is your counseling?
We will tell them that there is a good 25% chance the next born child might have the same disease.
But doctor, all my children are affected, so this is 100%. It's not 25%.
Antenatal screening can be done with.
Answer this question first, because you need to understand this even when you are counseling. You're right, autosomal recessive is 25% chance.
What is the mother's
Then how
age?
did all the 4 children get
Mother's
affected?
age? 40.
Each individual child has a 25% chance.
So each individual child has 25% chance, and unfortunately in this case, each time it fell into
the
that
25%
25% group and not in the 75% group. So now what will happen next time?
The next born child may also have the disease, and so
But is it possible that it may not have the disease?
it is possible that
So then what should they do?
So you can say that 50% chance is there that a child will like you both, where half the disease there it will not express. 25% chance is there that the child will be absolutely normal. 25% child will be low. Now somehow it has so happened that all the 4 children are affected. Next time again the same thing happens. You don't know what will happen. Okay? So then what will you say? I want the child. I am 42 but I want the child. Doctor, do what you want.
So we will have to keep a close monitoring, frequent visits with antenatal testings,
So
frequent
prenatal
sonography.
testing possible in this disease? If there is prenatal diagnosis possible in disease by doing karyotype etc. after doing amniocentesis, then that option is available. Otherwise, do you think that it is advisable to have a child? There is good chance that the same history will repeat. Okay, though it looks as if 75% chance is there that a child is normal in each pregnancy, somehow it has happened. So you decide whether it is feasible or it's still right for you to take the decision of having a child now this time.
So have you read up, is antenatal diagnosis possible?
No.
You not read up, or it's not possible?
I am not aware of.
So next time you tell us. Now Dr. Mahesh Moite is asking that how is mitochondrial disease genetically transmitted? Is it AR or is it something else?
It is autosomal dominant only from mother. If the mother is diseased, completely comes to all the children.
Yeah, so there's something called mitochondrial gene transmission. So he's suggesting that this could be mitochondrial gene transmission and not just autosomal recessive. So I don't know that. You'll have to check that up. Second thing he's saying is autosomal dominant is 50% to the next generation. So how will you answer that? Like you said just now, 50% only for every child. So that doesn't mean anything. It could well be all the children, right? Okay. So next time you are going to tell us 2 things, whether this is autosomal recessive or whether this is mitochondrial gene, and that will decide whether we tell them whether antenatal diagnosis is possible or no.
No, it is autosomal recessive according to the genetic testing, they have given autosomal recessive, sir.
Yeah, I said that here I saw that it is written here as autosomal recessive, but just check on that. And the second thing is whether antenatal diagnosis is possible. Correct?
Yes.
Theoretically, it should be possible, no?
Yes, sir. Theoretically, from
Yeah. Okay. Fine. Anything else on this? Sir.
I'll tell you, one for the exams and two for your lifetime. You must know natural history of every disease that is likely to come in your exam, and it is not taught in medical colleges. So you have to do your research. There are 20 guys, suppose you are 20 guys, you divide your exam illnesses, each writing down natural history of that disease, and then we share. So you all become good at that and you score over the world. Number one. Number two, it's simple. What is natural history? You ask 6 questions. What is this? Why this happened? When it happens? You write down these 6 questions, or you write on, see on internet 5H and 1W. Okay, and you will get them. See, what is this illness? When it happens? Why it happened? Where it happens? Why me? Why my family? And natural history is from womb to tomb what happens, and what I will do if this happens to me. If you are able to answer this, you will do the best, you will top the stuff, number one. And for lifetime, the more learned you are, more bad communicator we become by default. Our non-MBBS guys learn in local language, talk in local language. And we by default cannot talk one sentence in mother tongue without English. So we communicate bad. We fail in life, number one. So much that when a pediatrician tells you have HIE grade 3, parents feel, wow, my baby is great. And when the baby dies, they kill the doctor, or they sue the doctor, or they hit the doctor, whatever. As long as you keep garbage in, garbage out, this will continue. As long as you continue learning in English and talking in English mixed your tongue, this will happen. After you pass, try to learn everything in the language of the people where you will practice. Thank you.
Thank you. So we now move on to the second case for today, which is being presented by Dr. Amruta.
Good evening, everyone. Myself Amruta from Sion Hospital, JR2, presenting a short case for today. Tanuja, 3-year-old female child, third by birth order, born out of non-consanguineous marriage, resident of Kurla, hailing from Nanded, Maratha by community and Hindu by religion, brought by parents with complaints of abdominal distension since 2 months, fever since 2 days, and cough since 2 days, increased work of breathing since 1 day. Mother noticed that child has abdominal distension since 2 months, incidence in onset, which is more in the upper abdomen, and is gradually progressive, not associated with pain or no positional or postural variation. Currently, child presented with complaints of fever since 2 days, moderate grade, undocumented, continuous type, not associated with chills or rigors, relieved on medication, dull during interfebrile period. And child had such fever episodes once in almost 15 days as per mother, which lasted for 2 to 3 days since the age of 1 month, associated with cough, cold, which relieved on medication on OPD basis, and did not seek any further medical advice. The cough since 2 days was productive type, yellow to greenish colored sputum, which was gradually progressive, no diurnal variation, no aggravating or relieving factors for cough. Increased work of breathing since 1 day in the form of increased rate associated with chest retractions, and no history of aggravating or relieving factors with change in position. And also child has lethargy since 1 day and decreased oral intake since 1 day, associated with decreased urine output since last 1 day. And on inquiry, mother also mentions that child is not gaining weight appropriate as per age as compared to the elder siblings. There is history of Cox contact. Father is a case of pulmonary Cox on anti-AKT since 3 months. There is no history of bowel bladder disturbances. There is no history of bowel disturbance, vomiting or abdominal pain. No history of edema, decreased urine output, but decreased urine output since last 1 day. Altered urine color. No history of jaundice or bleeding manifestation. No history of bony pains. No history of altered sensorium. No history of any neurological deficit. No history of blood transfusion in the past. So past history, no similar complaints in the past. No history of any hospital admission prior. Antenatal history being uneventful. It was a registered pregnancy. Regular antenatal checkups, ANC scans were done and were told to be normal. No comorbidities in mother like PH, diabetes mellitus, hypothyroidism, and no history of blood transfusion in mother. Birth-wise, she was a full-term normal vaginal delivery, cried immediately after birth. Birth weight approximately of 1 kg, which mother doesn't remember. Required 8 days of NICU stay for weight gain. No history of neonatal jaundice. Development is appropriate for age. By gross motor, child can run, play with peers. Fine motor can change clothes by herself, can draw a circle. Language-wise, knows full name, age, and sex. Socially, she plays and shares toys. Immunized, she's partially immunized only with the birth vaccine. Diet history, there is significant deficiency in calories and proteins, being 1010 kilocalories and 8 grams of proteins. Family history, child is third by birth order. Father is a case of pulmonary Cox, and family belongs to lower socioeconomic status according to modified Kuppaswamy classification. So,
so let's start thinking and analyzing. So 3-year-old girl comes with abdominal distension since last 2 months. So what are your thoughts? Is abdominal distension, what is the anatomy of this abdominal distension? So is it gas, flatus? Why?
2 months history.
And one more question which we'll ask, which will rule out gas. What will confirm that this is flatus? So relief, so up and down, waxing and waning. So if this is waxing and waning, then it is flatus or feces, constipation. Okay? So if it is not, though that history is not there, those two are ruled out. Fetus is ruled out. So what are we left with? Fluid and organomegaly. So now decide between the two. He gave you some more history also. So
in these 2 months, is it progressive?
yes, sir, progressive.
Just notice 2 months back, and for last 2 months it has been progressive.
Yes.
she gave this history of abdominal
Actually,
distension.
sir, on so much of deeply asking and probing the mother, she is telling since 1 month of age only child's belly is protuberant and she has pot belly, but last 2 months she is significantly noticing that there is distension of abdomen.
But she came for distension of
No,
abdomen.
she came actually for fever, cough, cold and increased work of breathing.
So increased abdominal distension was noticed by you,
And
and
we
then you
asked
ask
mother.
her pet kabha puja, they say yes, abhi
Yes, she
before
has
that.
noticed.
I think these two things are a little different. Somebody presenting with abdominal pain, abdominal distension, marked abdominal distension noticed by the parents. Okay, and here doctors have noticed that there is abdominal distension, and then mother agrees that yes, it is there, but she says that it is there from birth only. So what is your interpretation if it is there from birth? Does a newborn have a scaphoid abdomen? If he has a scaphoid abdomen, it's abnormal. Every newborn has a little bit of a pot belly. So it depends upon what is the mother's and understanding of what the newborn's distension should be. So it may be, for all you know, may be normal. Today also they may not have been very marked to the mother, but after saying that it is there, that yes, it is there, and she said that is it progressive, that also was a leading question. ये 2 महीने से बढ़ते जा रहा है कि इतना ही है?
It was a leading question.
Leading question. So we just keep a note of that.
So these are all the problems in history taking. So as sir said, if they didn't come with abdominal distension as a chief complaint, it has a totally different meaning, right? But for a moment, let's sort of analyze or discuss that if they had come with chief complaints of abdominal distension, what all would you have thought of? So here, first question you would have asked is abdominal distension since 2 months. So first question you would have asked is onset. So was it not there 2.5 months back? And then immediately she's saying that way, so it's there since birth. So it's all gone. The history collapse is there only. But if it's a genuine distension for 2 months, then what all would you have thought of? We said we narrowed down to flatus and fluid. Differentiate between organomegaly and fluid. Differentiate between the two.
So if it's there since 2 months, it can be fluid and ascites which is developing.
Fine. So take it further. Suppose it is fluid and ascites. Then what is the anatomy behind that ascites in a 3-year-old child? So think of all the 3-year-olds you have seen with ascites and start ticking them off. So what is the commonest you have seen a 3-year-old with ascites? Nephrotic. Can it be nephrotic? Huh? Yeah, so why should, if there is anasarca, why should they say abdominal distension? Even if they are not well informed, one question, is there any swelling anywhere else? If the answer is no, it is out. So nephrotic is out. Then?
Associated with jaundice.
Okay. So let's take that further. So associated with jaundice means you're talking of liver disease. Acute or chronic? Chronic. So chronic liver disease will come with jaundice necessarily?
Not necessarily.
So what will they come with? Growth failure, pedal edema, much before this distension of abdomen. So that also you would have asked and you would have found that it is not there. Then severe acute malnutrition. So how will you find that? So will they have distension of abdomen for last 2 months?
No.
It will be long back. So again, the moment she says it is long back, you already start thinking whether it is just malnutrition and a poor muscle tone and nothing else. If it is there right since birth, as she is saying, right since 1 month of birth or whatever, right? Okay, what else? Fluid, what else?
So like one thing came to my mind. So like I said, hypothyroidism, they come with as a pot belly. So do we describe them as distension or swelling?
Yeah, they can describe. So how will you rule it out?
So other features of hypothyroidism we can ask for: constipation, lethargy.
So what I am trying to say is, how should your thought process be? More commoner is intra-abdomen. So intra-abdomen, we said flatus, feces, fluid, and then organomegaly. So first take these in your mind, intra-abdomen. So younger the child, don't rule out feces so easily. Think whether this is Hirschsprung's. So ask for history of stools, how are the stools, etc. Right? Once you, suppose you find that it's not, so as I am discussing, you ruled out nephrotic, you ruled out liver disease. What else as a cause of ascites in a 3-year-old? You've seen any other ascites? So these are the two most common. Rarely cardiac. But again, what will cardiac come with? Breathlessness as the chief complaint. So that is also ruled out. Malnutrition ascites, we have always said, is never clinical. It is on investigation, right? So that is also ruled out. Means the distension of abdomen is just the pot belly of the poor muscle tone of malnutrition. So and it's chronic. So acute things like dengue are ruled out. So you realize that it can't be fluid. Now you come to organomegaly. So which organomegaly can come to you for a 2-month duration? 2-month duration means liver spleen organomegaly, right? So liver spleen 2-month duration at 3 years of age. Start thinking all the causes. What can it be?
Hemolytic disease.
Very good, hemolytic disease. So what question will you ask?
History of any blood transfusion.
And pallor, severe pallor. So if that is not there, and which hemolytic disease starts at 3 years of age? Thal intermedia starts at 3 years. So hereditary spherocytosis has a splenomegaly, not a hepatospleno, right? So classic hepatospleno is your all the thalassemias. So they would start even earlier, but TKHL they didn't notice or whatever. So you'll ask for blood transfusion, pallor, etc. What else? So look at all the groups which can cause hepatosplenomegaly. That's one way to go at it. The other way to go about it is whenever you have a hepatomegaly, how should you think? What are the 4 parts that you should think of? Parenchymal disease, biliary tract disease, reticuloendothelial disease and vascular system disease, right? Now biliary tract disease is ruled out already. How? No jaundice. So ruled out. Okay. Now venous system disease has to have what? Ascites. So clinically on history we don't know whether this is organomegaly alone or organomegaly with ascites. So we'll keep that for a while, right? Then parenchymal disease. So what are the features of parenchymal disease?
Growth failure.
Poor appetite, growth failure. So we need to ask prior to this 2 months, how was this child? Was this a well child or no? No. According to you, he was not. So then that topic is, it is possible that it is started much earlier, the whole disease, and not just the 2 months, right? So that is about parenchymal disease, and last is reticuloendothelial. So if this child was a well child as in no symptoms prior to this could be reticuloendothelial hyperplasia, and you are then looking for constitutional symptoms, fever, any other symptoms to corroborate that, right? If you feel it's not fitting in anything, then you come to those external causes. So here she is already saying that it is there from even much longer. So then you start thinking whether this is just poor muscle tone, malnourished child, etc., and there is no organomegaly at all, right? So that's the way you will think about that abdominal distension.
Yeah, just coming to the hypothyroidism as you mentioned, hypothyroid will come with abdominal distension or delayed milestones. What will strike the parents more? Delayed milestones.
And what is this respiratory thing now? Fever, cough and increased work of breathing. So what can it be?
Could be a pneumonia.
It could be a pneumonia, it could be anything else. Acute asthma, it could be acute asthma. It could be acute viral infection with, so like a bronchiolitis type or a wheezer, a viral infection with wheezing, not bronchiolitis, 3-year-old. So viral infection with wheezing, right? So what we are just trying to point out is that if this history is right, and if the cough is pretty soon along with the fever, then it suggests a infection which involves the airways. So either viral or any of the other infections which involve the airways. If the cough is significant and pretty soon with the fever, right? Okay.
And for organomegaly also, 2 months is relatively a short period for giving rise to significant abdominal distension due to, let's say, hepatomegaly or splenomegaly. Upper abdominal distension we often call as hepatomegaly or hepatospleno. Mainly splenomegaly will come more with an lump in abdomen. So here if it is there, then 2 months I thought was little too short for significant abdominal distension to be noticed by parents, complained of. But here it is not the story. They are not complained of abdominal distension, so it's not a presenting symptom. Am I right?
So, but when we ask the mother, she's telling yes, it is abnormal according to her and it is there, but she's not presented with that.
Okay, we'll keep that in mind.
So I'll give you one or two examples in the history which made me feel that this history is not very good, or this mother is not giving a very good history or whatever. I'll tell you some other examples. Meanwhile, Amdekar sir is making one more point in the previous case. There has been no seizures at all in spite of severe progressive disease. So that suggests mainly white matter disease. But sir, there is a lot of cognitive delay as well. I mean cognitive regression as well. And this child was cognitively also normal. So your point is well taken that no seizures is a point against grey matter. But there are other indicators of grey matter involvement in the form of cognitive regression. Okay.
Yeah, the point is what started first for classifying. Ultimately, grey and white matter will merge in advanced disease. What started first? And grey matter with regression of abdominal seizures. If it was extrapyramidal system, nowhere the extrapyramidal systems were involved. If it started with change in tone, which is this child has, it has started and progressively involved everything in the brain.
Okay. Now I want you all to think properly and tell me what you feel about the first sentence. Cough since 2 days, productive type, yellow to green colored sputum, progressive, means cough is progressive. So have you seen yellow to green colored sputum expectorated by a 3-year-old child? Yeah? Yeah. So again, this is something where you have to get into the details of the history. So many times the nasal discharge is described as cough or sputum by the parents. If the baby vomits and some sticky material comes out, it is described by them as sputum. Honestly, if it is genuinely wet cough with a sputum, then it is literally suggestive of bronchiectasis or something in this child, if it is really genuine, right?
And a 3-year-old child will not expectorate and he will swallow rather than spit out. Older children can spit out.
Okay.
If he vomits, it may come out, but otherwise no.
Then lethargy, decreased oral intake, all that suggests that this child was sick. Increased work of breathing, chest retractions, not necessarily pneumonia, it can even be wheezing, we don't know, because there is so much of cough. Let's see. Now, not gaining weight, okay, go on. History of coughs since the last 3 months, okay.
To distinguish between, as he said, pneumonia and airway disorder, you ask in how many days the child was better. If it is pneumonia, he is not.
This
going
is
to be
a acute
better
illness, sir, just 2 days.
Yeah.
So child is not
No,
yet.
the previous ones.
Ah.
Previous ones, the child had been sick for few days with cough cold and breathlessness.
Not breathless, only
cough cold, and was never hospitalized.
No.
So pulmonary problem or parenchymal problem is less likely. Airway problem is perhaps more likely.
Yes.
Okay, go on. One minute. You're jumping too fast. Next slide. Okay, next slide. Now, is anybody awake?
Birth weight of 1 kg.
Very
and,
good.
NICU stay.
Very
in
good. So thanks.
Claimed a full term.
Thanks for being awake. So now what bothers you about birth weight of 1 kg?
IUGR
Say something more.
term.
Full term
term
baby
IUGR.
with a birth weight of 1 kg is very, very difficult to believe. If a full term baby is 1 kg, then it means what type of IUGR it is?
Symmetrical.
Symmetric IUGR. And if it is symmetric IUGR, what was there in the history which went against that later?
ANC is normal.
Absolutely normal.
Normal.
There is no need of a catch up. So these two things don't go hand in hand, right? So either the 1 kg is wrong or the full term, out of which, because the development is so bang normal, full term is right, so the 1 kg is wrong.
And 8 days you wouldn't have been discharged, 1 kg.
Exactly, yeah. Yeah. Okay. So next. Okay, now dietary history, anything, is anyone awake?
The protein component does not seem very bad as compared to the calorie deficit.
Yeah, but the calorie deficit is extremely bad,
Extremely bad.
right? So now, again, see, when you, this diet is today or all along these 3 years?
Along these 3 years. Matlab, just before the illness, when the child was taking, it was poor diet.
Correct. So then if it is that bad, then you expect a very malnourished child, right? Okay? Yeah.
And
fine.
then even the gross motor are likely to be affected
Yeah,
in this particular
yeah.
child.
Okay, go on. Go on. There's something more in the which bothered me anyway. 1 month wala wo kidhar gaya tera sab, from 1 month of age?
Yeah, in the beginning only.
Fever episodes once in almost 15 days.
Once in 15 days since the age of 1 month, associated with cough and cold. So anything hurts you in this history? So how does a 1 month old get fever, cough, cold? From where do they get it?
Generally, elder siblings or
So from a family contact. So can they get every 15 days fever, cough, cold right from 1 month of age? Right? It's not possible. Okay, from a family contact it's not possible. So again, either it has to be a big disease like say cystic fibrosis, when the fever will be very prominent, child will get hospitalized, or there is no fever and it is a reactive airway disease, that also at 15 days, 1 month to start is very, very unlikely.
In fact, he may give us suggestion whether we are dealing with a cardiac problem. with
Exactly,
cough, cold.
exactly. So we are just trying to tell you that these are some things which you should immediately, your antenna should go up, that this can't be right. So let me dig into this. We are not blaming you. What we are trying to say is that whenever you get such history, you need to get deeper and sort it out.
So the onset of 1 month age is also just mother is telling 1 month.
I know. She's just selling it loosely.
What is important to you may not be important to her. Today she is bothered about मेरे बच्चे को जल्दी ठीक करो भेज दो.
Okay. So earlier Khare sir asked how soon did it get better? So Dr. Moite is making a similar point that reactive airway disease after viral infections will in fact take longer to get better compared to a bacterial infection which is treated appropriately. So if you treat a pneumonia nicely, it gets better quickly in 3-4 days, right? Okay, fine. So now you put everything together and tell us what are the possibilities in this child. What all have we found? We found that this is a malnourished child. right? That's one thing that we have found. What else? This child has never been alright, because that this story is only of 2 months, but this child has never been alright. We don't know the exact details of the sickness, but there have been repeated respiratory complaints. Correct?
Yes. But actually the respiratory complaints were also not that significant. The fever was very significant according to mother. But she is telling cough, cold was there.
So cough cold was also there, but
Was also there, but fever was more prominent than cough cold.
But still settled in 2-3 days with
Yes,
local
sir.
treatment.
Yes, sir.
And it did not recur for good 1 month.
No, she was actually 15 to 20 days she was always having fever, and then requiring some OPD medications which she was getting better. But according to mother also, she is not alright at all till now, till 3 years of age.
So we have a malnourished child, we have some respiratory complaints which don't seem major, but there is some vague history of fever. Now fever also, if we take that fever as significant, then over a duration of almost 2 years, as in if the baby is 3-year-old now, and the fever duration is 2 years, since the first year there is fever, right?
Yes.
So all that doesn't fit in. If it was a chronic infection, it would have manifested much earlier with something else. So we can't say that this chronic infection started at 1 or 2 or 3 months of age and has come to light at 3 years of age. That's a little too far-fetched. So something is wrong in the history somewhere. And similarly, there couldn't have been so many minor illnesses at that time also.
Yeah, but mother is grossly telling ki there are illnesses in between, but may not be every 15 days, sir. But child has been ill in between.
Fine. So now, how would you correlate everything just now? So what else you have? You have a father who's active case of pulmonary tuberculosis. You have a malnourished child, and you have this respiratory complaints just now, which we discussed are not necessary. So how prominent is the cough now?
Significant, sir. She has a cough which is acute onset and also increased work of breathing associated.
Increased work of breathing, yeah, but cough is also significant.
Yes, sir. It is
Okay.
significant.
And fever is again high fever,
Yes.
prominent high
In
fever.
hospital stay, she had 38-39 degree fever.
Right. So, I would say that clinically you would say because this is a malnourished child and just now there is a acute respiratory infection for sure. From the history, if cough is significant, it sounds like a airway disease. So we don't know whether it's viral or bacterial airway disease or what, we are not sure. Whether it's parenchymal also we don't know, we'll have to check on examination. And we have to keep in mind that family history of coughs. So whether this child being malnourished is also having coughs right now, that also we have to keep in mind, right? Okay. So what's your summary?
So to summarize, 3-year-old female child which was small for gestational age with developmentally normal, partially immunized, belonging to lower socioeconomic status with significant calorie protein deficiency, with family history of coughs and also had recurrent illnesses, presenting with LRTI and probably organomegaly. For differential diagnosis being tuberculosis is the main thing which I kept in mind.
So according to you, if there is tuberculosis, when has the tuberculosis started in this child?
Father is diagnosed 3 months back, maybe.
So the
that
father may be suffering for not more than 6 months, and the child has started 2.5 years back. So if it is tubercle, then he was suffering from something else earlier. He certainly was not suffering from tuberculosis from an infancy. Untreated, he would not progress up to 3 years with 1 year tuberculosis, it would have been disseminated. And the father is only suffering from, so at the most he must have given infection to the child in last about 6 months max.
And also, so when you say pulmonary with abdominal cox,
Disseminated.
so you'd rather say disseminated rather than pulmonary with abdominal, because abdominal is, you're talking of intestinal or something which you don't know. You don't have any such complaints on history, right? So therefore, you'd rather say disseminated cox. Okay. Examination.
So examination, on presentation, child appeared lethargic, preferring to sleep with heart rate of 130 per minute, regular rhythm, respiratory rate of 44 per minute with subcostal retraction and intercostal retractions. Saturation was 94% on room air. Extremities being warm, peripheral pulses were well felt.
Okay, one sec, go back. So see, again, if your findings are right, what do these findings tell you? Is it parenchymal disease or airway disease?
Parenchymal.
Why parenchymal disease?
Intercostal.
Intercostal and intercostal.
So when do you get subcostal retractions?
Morning airway.
Subcostal retractions is airway expiratory obstruction, right? So either it is airway expiratory plus parenchymal, okay, or in a severe stage of respiratory distress, then you get everything involved, right?
But for that, the RR of 40 was a little
is low.
less, yeah.
Okay. One sec. So, Dr. Mahesh, we have discussed all what you said, that those parts of the history are not clear. So, we don't know whether the child was respiratory symptom free between fevers. There was no admission needed at all. And about you saying it is still recurrent viral, there are two problems. One is this is a malnourished child looking at the whole history. And the second is that she's saying it started at 1 month of age. Nobody gets recurrent viral from 1 month of age and every 15 days. So what we are just trying to say is we don't have a good history there, clear history to make much out of it. But as Khare sir also pointed out, we are not saying that the tuberculosis started at 3 months or 6 months of age and is presented at 3 years of age. That is also not possible, right? Yeah.
Anthropometry, weight being 7.7 kg, which is less than -3 standard deviation, height of 79.5 cm, less than -3 standard deviation, weight for height is less than -3 standard deviation, but head circumference was 46 cm, -2 to -3 standard deviation, mid upper arm is circumference is 11.4 cm.
Okay. So now for a moment, if you ignore that 1 kg at birth, then what does this weightage and heightage tell you? Again, just for practice sake, weightage is how much? Yeah, so 9 to 12 months, whatever, depending on what was the birth weight. Okay, and heightage 1 year 3 months to 1 year 6 months, and chronological age 3 years. So again, pattern of chronic malnutrition, height more affected than weight, both are affected, and weight more affected than height, both are affected, and we have a very stark history of dietary inadequacy, right?
Head circumference?
Actually, I didn't type it, right? It is 46 cm, -2 to -3 standard deviation.
Just one sec, doctor. Going to this weight chart, see, this weight chart is so crowded in the first 2-3 years of life, and where the weight charting is most important, it will be very difficult to find out where the percentile the child is. First 3 or 4 years is very crowded. So these charts are suitable for a child older than 4-5 years of age, because there they get separated. Otherwise, it will be difficult to find out. So we need different charts for children below the age of 5 years.
Dr. Mohite is asking, is this child in respiratory failure? How will you answer?
Sensorium was normal.
You said no, lethargic.
Impaired. Failure.
There will be bradypnea, poor respiratory efforts.
That is last stage of respiratory failure.
Respiratory rate is 44 with subcostal and intercostal retraction. Means we don't have nasal flaring, head bobbing, grunting yet, and saturation is 94% on room air. On room air.
So again, so what are you trying to say? First complete, then I'll ask you. So you said no nasal flaring and all that means what? He's not in respiratory failure.
He's not progressed towards, he's in respiratory distress but not
in
failure.
So exactly. So how do you decide that a given child is in respiratory distress but not in failure clinically?
There'll be very strong voluntary efforts, breathing wise, like.
So is there can you measure the strength of the effort? So that's not the criteria. And if somebody has a airway obstruction, he will have maximum strength of the effort, right? Somebody has a inspiratory obstruction, there will be marked stridor and marked indrawing. So that is not the criteria. So what does the clinically, if any organ you have to say that this organ has failed, it should equate to what?
What should it give rise to the hypoxia?
It should equate to that organ has not been able to do its function, which is clinically visible, so much so that it is affecting other organs. This is the concept of any organ failure clinically. So when do you say their child is in hepatic failure? When liver function is not being maintained, so you have jaundice or you have edema or you have bleeding, so much so that it is affecting another organ, encephalopathy. So if this liver child is getting drowsy, then you say clinically he is in hepatic failure. So a respiratory failure, you should have clinical signs of hypoxia or hypercarbia and affection of the sensorium, another system. That would tell you that this child is in respiratory failure. So these extra efforts, tachypnea, all these are common to respiratory distress and respiratory failure, and you cannot quantify it. So 60 is respiratory failure and 59 is not right. You have to see what is the final effect. So in principle, respiratory distress is doing extra work but getting the required oxygen. That is respiratory distress. And respiratory failure is doing extra work but still not managing to get the oxygen needed. That is respiratory failure. So you have to decide clinically. So signs of hypoxia are tachycardia, all that vague signs, then your pulse ox, and then your sensorium.
And perhaps grunting also. If you see severe grunting, because grunting is where the child is trying to maintain the end oxygen pulmonary in order. Well, that is why it is grunting, because expiratory pressure is increased. That means he is going in for failure. So clinically, cyanosis or evidence of circulatory failure, grunting and CNS changes. And if you have a pulse ox, that.
Okay, go ahead.
So child had pallor, no icterus, had a sallow complexion, dry and hyperpigmented skin, no edema or cyanosis, visible wasting was present, head was normal, scalp normal, but hair were lusterless, and eyes dry conjunctiva present. Oral cavity was normal, no signs of any micronutrient deficiencies. Gums are normal. Bilateral multiple enlarged discrete cervical lymph nodes present, largest being 0.5 to 0.5 centimeter in submandibular region. Chest, no deformity or no signs of rickets. Upper and lower limbs were normal. Spine being normal. Genitalia were normal. So, coming to systemic examination, respiratory system. Inspection, trachea was central, chest symmetrical, tachypnea present with the subcostal intercostal retraction and also nasal flaring. Palpation, trachea central, chest expansion was bilaterally equal. Auscultation, air entry was equal bilaterally. Crepitations present in right mammary, inframammary, axillary and infra-axillary areas.
Not on the left side.
No, sir.
Only right side.
And not at the back. You said axillary,
Axillary,
infra-axillary
is there.
and
No.
mammary and inframammary. So only front and axilla.
Back, I couldn't appreciate. Per abdomen examination, abdomen appears distended, umbilicus pushed down, no scar, sinus or dilated veins. All quadrants move equally with respiration. Hernial orifices appear intact and flanks not full. So this is the image. Actually, there is one burn scar which the child had at around 6 months of age. Child had a burn with hot water.
Okay.
Palpation, abdomen is soft, non-tender. Liver palpable 6 cm below the right costal margin, span being 8 cm, smooth in surface, rounded margins. Left lobe of the liver palpable. Spleen was 6 cm, smooth surface, firm and rounded margins with splenic notch not felt. And percussion, liver span 8 cm, no shifting dullness. Auscultation normal, bowel sounds were heard, no bruit.
This child is not here, no?
Actually, sir, till yesterday child was actually being stabilized, but since night he has distress again, so on oxygen.
Okay.
Then cardiovascular system, apex beat in left fourth intercostal space, medial to mid clavicular lines. First and second heart sounds were heard, no murmur. CNS wise, higher mental functions were normal, cranial nerves were normal, sensory and motor systems were normal. My provisional diagnosis.
So is this liver abnormal or normal?
Abnormal,
Why?
enlarged and
8 centimeters at 3 years.
What is the span at 3 years which is normal?
5.
So it's borderline, I would say, in
Birth
terms
is
of the
5,
span.
So just
Yeah.
borderline.
And so what else will decide whether this is normal or abnormal? Left lobe and firm consistency. So you need to insist that it is firm in consistency. You didn't mention, I think, consistency. So that is important, okay? And so the left lobe, so that makes it abnormal.
Could it be fatty liver due to malnutrition?
Yeah, first step is decide whether it's normal or abnormal. Even if it's fatty liver, to you and me it will be firm, because there is something new that is getting deposited in the liver, or the liver, I mean the architecture, parenchyma is changing, so it will be firm, right?
Sir, actually on presentation child had both liver and spleen, but during the course of illness the liver regressed, but again it reappeared today. It is there, hepatomegaly.
No, so that's why I'm saying now we need to decide whether this is just the pushed down liver or whether the span is actually more. So that's why if the span is borderline, then the question will be whether it is consistency is abnormal. So that will tell you whether it's abnormal.
Soft
And-
and consistent.
So soft, then it may not be abnormal. It may be just pushed down because of the respiratory distress. And originally this is a malnourished child, so there is visceroptosis and there is a poor tone of the abdominal muscles. So all those things can cause visceroptosis. What about the spleen consistency?
Spleen is firm in consistency.
So that's definitely
Abnormal.
abnormal.
How
right?
much is it?
It is
Palpable, she said 6 centimeters.
6 centimeters.
But the notch is not palpable, so it is kidney.
But we cannot insinuate fingers between
Good. I think
behind.
more important sign is whether you are able to insinuate the finger between rather than the notch. Good.
Okay. So, fine. So now what's your final diagnosis?
Bronchopneumonia with hepatosplenomegaly can be disseminated Cox or any hemolytic.
Why hemolytic?
Anemia, spleen, enlarged spleen.
Yeah, but which hemolytic?
Thalassemia.
Why
Major.
thalassemia? Which thalassemia? Major, minor? Anybody?
Minor always possible.
Let them say it. Come on, which thalassemia is possible, which is ruled out?
Not required any transfusion, so major is ruled out.
Major is ruled out. So you're left with minor and
Intermediate.
intermediate or beta plus thal. Your liver, you are still fighting whether it's abnormal, normal. So I think that itself rules out thalassemia. Because if it was thalassemia, the liver should have been very prominent and all that, right? So thalassemia is unlikely. Can it be any other hemolytic anemia? With spleen alone?
Spirocytosis.
Hereditary spherocytosis. So what should be there?
Jaundice.
Mild
Just-
icterus should be there, and you could find a spleen in the parents also. So means those are the ways to decide clinically. Then can it be sickle?
Wouldn't have hepatosplenomegaly.
Can have, at 3 years they can have, and in fact the Indian variety of sickle keeps on having spleen. They don't get autosplenectomy. So that's not the point. But what is the other point?
Crisis.
Yeah, so far there is no crisis. And again, if the liver, we are not very convinced about whether it's really enlarged, not enlarged, then how much is the pallor? So therefore those hemolytic anemias are not really sort of prominent in the diagnosis.
Sir, one question. Sir, had the child complained of chest pain along with these features like fever, breath, workout, breathing anemia? So then could we have considered like this acute chest syndrome of sickle cell?
First of all, this age child will not complain of chest pain, so that complaint of chest pain is out of question. Secondly, again, it depends on how correct we are in our examination, but that should give you bilateral signs. Here there are unilateral signs. So you have to decide whether you have a localized respiratory disease, which is like a localized infection, or you have a bilateral. Then you're talking of airway disease, interstitial, whatever, right?
Sir, and given that left lobe palpable, means that is also pathological hepatomegaly only. So
True. So what I'm trying
like
to
I
say
am
is
still
I'm not
debating.
saying this liver is normal. I'm saying this liver is abnormal. But then this is a malnourished child who anyway can have a hepatomegaly because of malnutrition also. So I am saying your diseases like hemolytic anemia or storage disorders should have a much bigger and a much firmer liver. Than you having to debate whether this is normal or abnormal or look for such features of abnormality, right? So that I would put lower down as a diagnosis. Then again, we try to fit everything into one diagnosis always. So if you just think back, I mean, nothing prevents a hemolytic anemia from being malnourished. But have you ever seen a hemolytic anemia who was severely malnourished? You have to scratch your brains. So you're trying to put it in two diagnoses, one malnutrition and one hemolytic anemia. So rather than that, think of what can cause that hepatospleno in a malnourished child, that way.
And so given this span to be near normal as per age, will we call it hepatosplenomegaly or splenohepatomegaly then?
That's technical. I think you can, whatever you say. So don't use the word only. You say liver is this, spleen is this. Okay?
So, can the right lower lobe pneumonia present as a falsely increased liver span? Can it give
No. Just a right lower lobe pneumonia, no.
mnemonic effusion with
No. That won't push down the liver. That won't push down. So liver will be pushed down in a airway disease. So that is why you have a lot of wheezing and air trapping and all that. So that is why liver spleen will be pushed down, not in parenchymal disease.
Sir, actually one more positive finding. The child has grade 1 clubbing, which I forgot to mention.
So that's why I said much earlier that if your history of cough in the first year is significant, cough and fever, and that sputum is significant, I said this bronchiectasis is like cystic fibrosis. So if there is definite clubbing, but again cystic fibrosis to have survived without admission till 3 years when symptoms started in the first month is also far-fetched.
And grade over clubbing, you be little particular because it's maybe not very convincing sometimes, especially of all nails, then of course convincing.
Sure, I think we have overshot our time, so quickly tell us the investigations positive. Don't read everything.
So CBC, there was anemia for HB 8.2 with MCV 93.4 and RW is increased 24, with platelet also being less 27,000, WBC were increased 14,800. On peripheral smear, microcytic hypochromic RBCs with few hyperchromic RBCs and few schistocytes, early normoblasts and activated lymphocytes, platelets reduced on smear.
So what does that suggest?
The hemolysis is there, so schistocytes present.
Okay.
And also bicytopenia with can be vitamin B12 deficiency also, or
So why from this picture B12 deficiency?
for HB of 8.2 MCV 93.4
Okay.
but there are microcytic RBCs.
That's what. So it would be means dimorphic by both deficiencies. In fact, your hyperchromic RBCs might bring in hereditary spherocytosis. So you'll have to think of that, whether there's a possibility. Okay, go on.
Then this is the X-ray of the child showing consolidation in the bronchopneumonia present. Right.
So actually bronchopneumonia is a word which is
bilateral, but more of right side.
Consolidation.
correct. So this is a consolidation. You don't call this bronchopneumonia.
You see that horizontal line, which is the line between the upper lobe and the lower lobe, restricting the upper lobe pathology by that line. So it's the upper lobe consolidation, especially around, and there is also involvement of the lower down, right paratracheal region.
Yes.
So it may be in 2 lobes in this particular. So it is disseminated, getting spread, whatever the disease is. Even on the X-ray, the liver looks quite big.
Yeah, that's what I was going to say. X-ray definitely suggests that there's hepatosplenomegaly.
And then USG abdomen suggests of mild hepatomegaly and moderate splenomegaly, with echogenicity of liver being normal and hepatic vein normal. Kidneys are normal inside. And then hepatoportal Doppler was done, showing mild hepatosplenomegaly with normal Doppler study. Then USG local for neck showing reactive cervical lymphadenopathy. Then on liver function test, total bilirubin is 0.3.
So all this is normal.
Yes, sir, normal. And iron studies were also normal. And vitamin B12 levels were sent, which was actually more 979.
Okay.
So HPLC was done, is also normal, sir.
Okay.
So we have sent lysosomal enzyme studies and RBC membrane studies. So the reports are awaited.
And how are you treating the respiratory infection?
Give antibiotics ceftriaxone for 10 days. Actually, child has recovered, sir. Since yesterday, child has again. Antibiotics were stopped after 10 days, but child is now manifesting with fever, tachypnea, and again O2 requirement. So we restarted on antibiotics.
Okay.
How would you like to prove or disprove tuberculosis? A strong chance that this.
A gene expert we had sent, sir, gastric lavage genus, which was negative. Monto test was also negative.
So what will you do? Are you happy because the gastric lavage is negative?
No.
Also, is the father being investigated as open
But he
case?
is not microbiologically proven. He is clinically diagnosed TB, sir. His microbiological evidence is not.
This particular child, it may be worth doing a scopy and trying to prove a molecular, microbiological, a microscopic diagnosis, the bacteriological diagnosis, because he has improved to a certain extent on treatment. But if there is an open case of, even if the father is negative bacteriologically, if he is suffering from 3 months and symptomatic, there is a fair chance that the father is pulmonary tuberculosis, an open case. And if the child has been in contact for 3 months, at least 3 months, if the father is suffering from 3 months, he must have infected even much earlier than he became symptomatic. And in a malnourished child, tuberculosis as one of the strong possibilities, if associated with other, is always there. So we cannot be very happy if we have a diagnosis regarding hepatosplenomegaly. We will have to poke further for there is or there is no tuberculosis in this child. Even if there is symptomatic improvement, radiological improvement after an X-ray, he should be investigated for tuberculosis, including a scopy and a lavage.
Okay. Anything else? Okay.
So what is your diagnosis?
Still disseminated cox is one thing. Otherwise, regarding with some.
Tell the complete diagnosis.
Sir, not come to the diagnosis set by investigation also.
No.
At this point, 3-year-old female child with probably disseminated cox with severe.
But now why you are saying disseminated cox? You have a localized lesion in the chest, which is more like an acute bacterial infection. You are saying it is responding to antibiotics. So that means that localized patch is not a cox.
Bacterial.
Yeah, and your liver spleen,
Is under evaluation.
you are still investigating. So you can't say disseminated cox now, right? See, even on history, this short illness of 2 days of fever, cough, couldn't have been means pulmonary illness of tuberculosis. No? Tuberculous pulmonary illness doesn't come as a short illness of fever with breathing difficulty over 2 days, right? So that had to be an acute infection, whether bacterial, viral, whatever, right? We were thinking of disseminated tuberculosis because of the father's history, those long-standing respiratory complaints which we didn't get a good history, and abdominal distension. So we were thinking from that point of view, not because of this current short illness, right? So this is now you don't say disseminated tuberculosis.
Bacterial pneumonia with hepatospleno.
With hepatospleno, where you have given those, differentials or investigations are being done, right? Yeah. But as Sir said, you can't rule out tuberculosis. You have to search for this in this child tuberculosis still. You have to prove it conclusively. Okay. Anything else? Any questions? Sir. We'll stop that or yeah. So thank you everyone, students and faculty who are with us online for all your inputs. And we stop this class here today. We once again thank Aristo Pharma for their educational grant, which allows us the live webcast of these classes. We meet once again next Thursday at 6 p.m. Thank you.